Good afternoon, everyone. This is Dr. Mohit Chaudhary, TransConnect, April 2025, and today we'll be talking about management of ABO-incompatible solid organ transplant immunohematology perspective. So it all started in 1951 when a 30-year-old woman received her first intentional ABO-incompatible renal transplant in Boston. And in their seminal paper, Hume and colleagues wrote that the blood group of the donor was ORH positive and the recipient was ARH positive. Thus, this presented with an incompatibility, and they found out that this was a blood group type incompatibility in the minor blood group. But the graft could not survive, and they went ahead with the second intentional ABO-incompatible renal transplant 1 year later, and this time they perfused the graft with 500 ml renal ringer lactate solution. They had 25 gram of albumin and 2 lakh units of penicillin were added, but the graft did not survive, and the authors concluded we do not feel that the renal transplant in the presence of ABO incompatibility is a wise thing to do. So that was then. Obviously, there is a natural gap between the donor and the recipient. There is a considerable gap in the demand and the supply, and you can know that renal transplant always scores over dialysis because dialysis itself has got a lot of morbidity and mortality. And why renal transplant is important and why ABO incompatible needs to be done is because of the ever increasing organ shortage, and there is increase in the living donor program. And within the living donor program, 20% of the eligible living kidney donors are blood group incompatible. All said and done, the AB incompatible renal transplant are very antigenic. The AB group is very antigenic. It can cause an hyperacute rejection when kidneys transplanted. AB incompatible kidney transplant has continued to be associated with greater expense, more immunosuppression, more morbidity, and that is why it is a thing that we should master, and what we need to do, we need to actually know about it. Now, small thing about ABO isoagglutinin, we know they are naturally occurring antibodies. They are called as ABO-Hemagglutinins, ABO-isohemagglutinins, or ABO antibodies. They peak at around 5 to 10 years of age and are detected at 3 to 6 months after the birth. Both IgM and IgG can agglutinate red cells at the room temperature or cooler and effectively activate the complement at 37 degrees Celsius. IgG anti-A and anti-B are found more commonly in group O, whereas it is IgM in A and B subjects. So these are incomplete antibodies, the IgG antibodies. Here you can see the distance between to actually cause agglutination is 24 nanometer, and once this can be covered with a penta antibody like an IgM antibodies, which is of 35 nanometer, whereas IgG antibodies, the distance spans is 14 nanometer and requires an AHG for causing the agglutination. That's why they are known as incomplete antibodies. Now, how does the hyperacute rejection occur when there is ABO antibodies? It is basically these preformed natural antibodies which bind to the carbohydrate structure present on the endothelial of the renal graft, and they fix the complement, activate the complement, and cause microhemorrhages and microthrombosis. Now, these antigens of the ABO system are glycoprotein. They are expressed on RBC membranes, we know, but they are also expressed on the epithelial and endothelial cells. And with regard to kidney, if you see, these are the glycoprotein expressed on the convoluted tubule and the distal convoluted tubules along with the vascular endothelial cells. They also have circulating epitopes of A and B, which are both soluble, and some are linked to the von Willebrand factor. These antigens, when free, are responsible for the ABMR. Now, A2 subtype does not have circulating antigen linked to von Willebrand factor. This is one of the causes why A2 subtype does not cause that much rejection. Also, the intensity of the antigen expression on the tissue is related to the acute rejection rate, and we all know A2 group has very less A2 antigen as compared to A1 antigens on the A group, and that is why A2 almost behaves like an O group. That's why whenever you call a clinician, you will see that the clinician will be very happy if the subgroup of the A is A2 because it behaves almost like an O donor. So we all know if there is no preconditioning and transplantation is done across the ABO blood group barrier, obviously this will lead to hyperacute rejection. So what is the rationale for reducing agglutinin titers? It is basically the common aim is to reduce the agglutinin titer to predetermined level for a successful ABO incompatible transplant. Now, what we want to do here is we want the accommodation to set in. Basically, what is that? It is the phenomenon of lack of rejection in the presence of circulating ABO antibodies, which are complement activated. This process takes almost 2 weeks. So when the titer is low, the accommodation sets in. Our goal is to reduce the titer to at least 2 weeks. And once it is done, the accommodation stays for a longer period of time. In fact, there are various strategies to reduce the agglutinin titers. It was 1987 uh, when Alexander et al. Actually documented the first desensitization protocol to prevent hyperacute rejection. The various strategies include antibody depletion strategies, B-cell depletion strategies, and IVIG. In antibody depletion, there is classical plasma exchange, which we all are aware of. You have DFPP and you have antigen-specific immunoadsorption columns as well. Now, B-cell depletion you can do by splenectomy, we know, but that has got its own inherent risk. So nowadays, splenectomy is not advocated. Instead, we have a monoclonal antibody called rituximab, which binds to anti-CD20 and causes B-cell depletion, which occurs 1 to 3 days after administration and persists up to 2 years of. Now, bortezomib, we used to use in plasma dyscrasias like multiple myeloma. Basically, it damages the plasma cells, and that is why plasma cells or the memory cells which produce antibodies are removed through bortezomib. That is another B-cell depletion strategy. Next, we have the IVIG, which are administered after the plasma apheresis to reconstitute the natural level of antibodies. There is no uniform dosage protocol for IVIG. So various groups have devised their own desensitization protocol globally, including the Japanese, which resort to DFPP, the Germans, which use the immunoadsorption column. Japanese always, till a very long time, advocated splenectomy, which has been discouraged in the German, the US group, and the Korean group. And the conventional plasma exchange is practiced in America and Koreans as well. And you do IVIG as well along with that. So mixture of all these desensitization protocols are practiced globally in the world. So now we have the following established point in ABO-Incompatible. We have come we've come very far in this, and now we are mastering this ABO-Incompatible transplant. So far, these are the established point. That is one of the very important thing is ABO antibodies can cause hyperacute rejection in incompatible kidney, liver, heart, and transplant. There are various desensitization strategies, B-cell depletion strategies. Splenectomy is not recommended anymore. Independent of whatever strategy is used, you need to reduce the titer to a predetermined level. The titer is less than 1:16. In liver, up to 1:16 is tolerated. The lower the titer, the better it is. There are various advanced technique and a consistent method is recommended. It's not like today you do a titer with one method and tomorrow with another method. So basically, consistency is very important. Even if you are doing with a tube method, you have to report the next titer as well with the tube method. So once you are doing with tube and then you're doing with an SPRC or a CAT technology, won't give you the predictable results. So what are the controversies? Not controversies, nowadays you can call it debate because these are open debates in ABO-incompatible renal transplant, which includes which apheresis technique to use, role of rituximab, what time it should be given, what is the dose, utility and role of IVIG, then method to detect isoagglutinins quantity and type, whether IgM versus IgG. What is the type of immunosuppression, whether three-point regimen or a 4-point, utility of post-transplant apheresis, accommodation, when does it set in, role of protocol biopsy. These are the biopsies that are taken post-transplant, whether the patient is performing well, the outcome is okay or not okay. You still do this protocol biopsy. And what are the principal complications? So coming to our immunohematology perspective, apheresis technique use is very important because it differs from the basal level of isoagglutinins. So almost all center have agreed upon the 1:8 titer or lower than that. But a good strategy is to have a twice documented stable titer within appropriate interval. Let's say 6 to 8 hours. A relevant question is to do what in the patient with low titer of isoagglutinins. Many centers still go for a plasma exchange even if the titer is well below 1, just to reduce the inflammatory mediators that may be present in the circulation. But nowadays, a tailor-made desensitization therapy is also available depending upon the titer. So if it is less than 8, so you can straight away go for induction and maintenance therapy. Whereas from 8 to 64, depending upon the titer, you can have rituximab followed by DFPP or immunoadsorption column. You can devise your own strategy, and that depends upon the combination of techniques that are available at your centers. So what are the method to detect isoagglutinins quantity and type of antibody? Very important question. Which methodology to employ? Whether you want to do a tube, if you're doing a tube, whether you want to do it with DTT or non-DTT, whether you want to do a CAT, that is the column agglutination technology, or SPRCA, or flow cytometry, which is very sensitive, but obviously there's a cost involved. What is the effective titer we have agreed upon? 8 is the titer, that is the cutoff. What is the TAT? At what, so suppose you want to give the results at, let's say, 36 hours, there's no point because the titer will change, obviously. It's the epitope which are generating antibodies at all times. So TAT has to be within 12 hours. And whether you want to do test for IgM, total antibody, that is IgM plus IgG, or only IgG, is something to be, uh, ponder upon. So antibody titration method, we all know what antibody titration, it is a semi-quantitative technique for measurement of concentration of antibody in a serum. So we do the double dilution technique or the serial dilution, and dilution is expressed as 1 in 16, which means the dilution factor is 16. So basically, the titer is simply the inverse of dilution. So what are the techniques? There is a tube technique, CAT technique, SPRCA, which detects only IgG antibody, and flow cytometry. So tube technique very commonly preferred. Doubling dilution method is how we do it. You can see in this picture here. And room temperature incubation technique and IIT have been interpreted as IgM and IgG respectively. So room temperature IgM, and when you do a IIT technique or a Coombs phase technique, you have an IgG which is detected. Both IgM and IgG of ABO antibody can agglutinate RBCs at room temperature or below and effectively activate the complement at 37 degrees. So very important, tube technique is practiced very widely all over the country, and the disadvantages include variation in cell suspension. Obviously, 3, 4, 5% cell suspension will give you different results because the cells are more. Then the cell loss may happen during wash-in. There may be some alteration in the ratio of cells to serum. Inter-observation is very common, very subjective. What is your endpoint, whether it's 1 plus or 0 plus, you need to know. And variation in the repeat testing. Very important technique conceptualized by Lapierre was column agglutination technology. It is very widely accepted all over the country. The principle is the controlled centrifugation of red cell with or without serum through the porous dextrin or polyacrylamide gel column of defined pore size and defined set of incubation. So most of the things are defined here. The gel will act as a sieve so that the unagglutinated cells settle at the bottom and cells form lattice get trapped at the various zone across the column. It can even give you a mixed field reaction. That is another advantage with the CAT technology when you have a mixed population of cells. So the Liz-Coombs gel card contains anti-IgG plus anti-CD3, which is available. The suspension of the cells is 0.8 to 1% Liz suspension, and this is how you perform it. The advantage is it is easily reproducible and more quality of grading. You can see you can grade the range of reaction from 0 to 1 to 2 plus 3, 4, or a mixed field reaction when you have two population of cells that are there. The inter-observer variation is minimal, less time consuming, very small volumes of serum and RBC is required, and the gel cards can be saved for future. So SPRC, another technique, very important. It is solid phase red cell adherence assay. It detects the antibody reaction which is immobilized on a solid medium. So this is how it is looking like, and it is fully automated. It has good reproducibility and it detects IgG antibodies. Flow cytometry obviously is very sophisticated. It basically means flow means in motion, cyto means cells, and metry means measurement. It is a very important technology which is very sensitive, and it makes use of the properties of cells or particles or the interest of the sample based on the markers present by passing them in a fluid stream or in a hemodynamic focusing. That is one cell at a time it will go and it will actually detect the fluidics of the cells. So it has got very high sensitivity and specificity, and it can also open the possibility of isotype specific monitoring. So what are the variation which may actually happen in antibody titer result? Depending upon the technology that you are using, it can be tube, CAT, solid phase, the volume or the pipette calibration, the diluent that you use may be saline, albumin, plasma, or serum. The incubation time may vary. The phase of the testing may vary. The cutoff that you are taking is very subjective. Some may, say 1 plus have the cutoff. Some may say weekly positive as the cutoff. and the cells used along with the human factor and the centrifugation speed and time. So, however, the most clinicians remain focused on the target titer. They do not bother whether it is what is the technology that you have used. It is up to you to tell them or not tell them, but always understand that you have to have consistent result. Then you have to have a consistent technology, same kind of sera, same reagents. All of that is very important. Once you standardize that, your results are also standardized. So one should be careful in interpreting the results of ABO titers, and this depends upon the method used for titer estimation. Nonetheless, automation and standardization is the need of the hour. This is a study done by Dr. Nayak et al. In comparative evaluation of 5 different methods for ABO titer, and it included the tube method to detect IgM, then AHG phase tube method for IgM plus IgG, CAT method, then CAT method with DDT, and SPRCA method just to detect IgG. There was significant differences in the ABO antibody titer readings from the 5 different methods. Anti-A and anti-B titers being higher in the tube method tested at AHG phase compared to all other methods. Reduction of the titer by DDT is nearly 50%, and there is a good amount of IgM type of anti-A and anti-B antibodies in the serum sample. There was poor agreement between AHG phase method and the gel card method, and there is differences in the interpretability of the ABO antibody titer among different techniques. Consistent and uniform application of a method for titration throughout the treatment of the patient is highly essential. This is another publication in which 6 centers got together and they did a survey, online survey, providing an insight into the practices of the titration in ABO-incompatible kidney and liver transplantation. And this was one of the largest, first of its kind survey undertaken among the transplant centers. And this effectively highlights the current trend and practices, and the protocols and everything was compared, and we found that majority of the centers have their own transfusion medicine department. There have been considerable differences in the technique used. However, the CAT remains, or the column agglutinin test remains, the preferred choice for majority of the centers. And transfusion medicine, which has such an important role in these ABO incompatible transplant, is emphasized in this paper. So another thing to question or ponder upon is which type of antibody. So whether you want to go for only IgG antibody because they are more clinically significant. We all know we have a longer half-life of them. They have a memory immune response. It is more resistant to plasmapheresis, can cause endothelial damage, and high kidney transplant IgG titers have been associated with AMR. So only IgG or is IgM significant? So there are various papers to substantiate the claim. So this is the paper which says that IgG antibody correlated well with the long-term graft survival. So IgG, we all know these are clinically significant antibody. This was done by Hiroaki Shimura et al., which described the role of anti-AB antibody titers in result of AB incompatible kidney transplant. This, however, another group of authors, that is Kim et al., they found that no difference in clinical outcome between patients with high or low IgG titers was seen once you are reducing the pre-kidney transplant IgM titers to 4 or less. So they had no hyperacute rejection after reducing the IgM titers despite the presence of range of IgG titers up to 256. This demonstrated that lowering preformed IgM anti-ABO antibodies enable safe kidney transplant. So IgM antibody is what they are emphasizing upon. This antibody, we know IgM is capable of complement fixation. The secondary antibody of IgG subclasses differs in response to the protein antigen. You know, IgG1 and IgG3 are capable of activating the complement more when as compared to IgG2 and IgG4. So that is very important. So which antibody or the subtype of IgG antibody is implicated is also equally important. Another paper which used the tube method, that is the IgM assay, and they found that preformed ABO incompatible kidney transplant without measurement of IgG, they had a graft survival of 95.2%. So they found that IgM, monitoring IgM antibody was actually sufficient enough for ABO incompatible kidney transplant. Another paper which was done by Takahashi, who is actually an authority in ABO incompatible kidney transplant, and they found that both IgG and IgM are implicated in one of the two phases, that is early and the late phase, compared to each other in the acute antibody-mediated rejection in ABO-incompatible kidney transplant. So British Transplantation Society also says that there is a IgM antibody which has been implicated. There have been reported AMRs in high IgM titers despite IgG low titers in blood group or recipients of A2 kidney. So yes, IgM has a role to play according to the British Transplantation Society. So coming to that, now we have come a long way. So take home message will be that from being unwise to transplanting in pre-formed ABO-incompatible antibody, now we have become a wiser and we have come along. There are many tailor-made strategies that are available for desensitization. Both IgG and query IgM levels are important in ABO-incompatible transplant. CAT is the preferred method, but SPA, RCA continues to be employed at various places. Standardization and consistency of titer is utmost important, and ABO-compatible and ABO-incompatible transplant are a reality now. We have got good clinical outcomes with both, provided you are doing the right things at the right time. Thank you so much. If there is any query, you can put on the message box. Thank you.